Hi dear students, welcome to another session on fungal diseases. So in this session we are going to discuss about systemic and opportunistic mycosis. Systemic mycosis are deep-seated fungal infections caused by fungi that are soil saprophytes. The infection is usually accidental and it is caused by the inhalation of airborne spores produced by moles. Dimorphic fungi are the causative agents of systemic mycosis and the examples include Blastomyces dermatitis, Paracoccidioides brasiliensis, Coccidioides immitis, Histoplasma capsulatum. First, let's see about blastomycosis. This is a chronic infection caused by the dimorphic fungus Blastomyces dermatitis. It is characterized by the formation of suppurative and granulomatous lesions in any part of the body, but with a marked predilection for the lungs and skin. As the infection is largely confined to the North American continent, it is known as the North American blastomycosis, and a number of cases have been reported from Africa, and also it has been isolated from Delhi from the bronchial aspirates of a patient and from the lungs of insectivorous bats. Soil is considered to be the source of infection, which is acquired by inhalation. Primary infection of the lung may resemble tuberculosis or histoplasmosis. It may be asymptomatic or may lead to focal or diffuse consolidation, miliary lesions or abscess formation. It usually occurs between the age group 20 to 50 years and it is more prevalent in males than female, and the ratio is found to be 4:1. And based on occupation, it is mainly found in farmers and tree cutters. The clinical forms include three forms. The pulmonary form is otherwise known as the Gilchrist disease or Chicago disease. It is usually asymptomatic. And there is cough, weight loss, chest pain and fever. When it is in the chronic condition, it resembles carcinoma or tuberculosis and also have the tendency to disseminate or spread. And the other form is the cutaneous form. It occurs through the traumatic inoculation into the exposed parts, and there is papule or nodule which breaks down to form a fistula discharge pus. And the third form is a disseminated form, and it mainly occurs in immunocompromised individuals. The other sites which is affected by this is the bones and genitourinary organs. Coming to the laboratory diagnosis of blastomycosis, the specimens can be sputum, pus and biopsy. Microscopy culture, skin test, antibody detection, nucleic acid detection with DNA probes and animal inoculation into mice, rats can also be used for the study of virulence. Microscopy can be done with 10% KOH or chalcofluoride. It's a fluorescent blue dye that is used to stain the pathogenic fungi, and when stained in the yeast form, they are observed as large yeast cell 8 to 12 micrometer, and the blastoconidia is attached by the broad base and their double contoured wall can be observed. And in the mold phase, we can see the lollipop forms. The culture media used are sabodextrose agar, brain heart infusion agar, blood agar. Two media is inoculated and incubated 1 at 25 degrees Celsius and 1 at 37 degrees Celsius for 4 weeks. This is to observe the dimorphic effect of the fungi. The colony on medium at 25 degrees Celsius are fluffy and tan colored. On LPCB staining, that is lactophenocotton blue, septate hypha with oval or pyriform conidia with chlamydospores which are thick-walled are observed, and the colony on medium at 37 degrees Celsius appear cream colored and smooth, and on LPCB staining, thick-walled yeast-like cells with broad-based budding can be observed. Conversion of the mycelial form to yeast form on blood agar occurs at 37 degrees Celsius. For skin testing, dilated hypersensitivity to blastomycin is done, but it is not of much value in the diagnosis. of blastomycosis. Antibody detection is done by complement fixation test, precipitation, immunodiffusion, ELISA, radioimmunoassay. Amphotericin B and ketoconazole can be used for treatment. In some cases, surgical excision need to be done. The next systemic mycosis is paracoccidioidomycosis. This is a chronic granulomatous disease of the skin, mucosa, lymph nodes, and internal organs. It is caused by Paracoccidioides brasiliensis. As the disease is confined to South America, it is called South American blastomycosis. Ulcerative granulomas of the buccal and nasal mucosa are a prominent feature of this disease. In this case also, the source of infection is soil. It grows in moist soil which is rich in organic material, forming hyphae with small pear-shaped conelia. The mode of infection occurs through the inhalation of the conelia and no man-to-man transmission is observed. In the primary infection, it acts as a pulmonary pathogen and it resembles respiratory diseases. And the females are less affected due to estrogen levels. It is more prevalent in the age group between 20 to 50 years. The pulmonary form of paracoccidioidomycosis is similar to the blastomycosis. It is having the Gilchrist disease or Chicago disease, and it is asymptomatic, and there is dissemination occurs through hematogenous route. Next is the mucocutaneous forms. It occurs in the cooler areas of body such as nasal and oropharyngeal airway, and ulcerative lesions are seen in mouth, on lips, tongue, and conjunctiva. In lymphatic paracoccidioidomycosis, cervical lymphadenopathy and can be spread to other lymph nodes. In disseminated form, it is seen in immunocompromised patients, and the disease spread to other organs, especially to the adrenals. The laboratory diagnosis of paracoccidioidomycosis got similar specimen collection and processing of specimen to that of blastomycosis. Microscopy is done by 10% KOH or chalcofluoride. The yeast forms with multiple buds encircling mother cell can be observed, and it is in the form of mariner's wheel or pilot's wheel or Mickey Mouse cap appearance. It's around 15 to 30 microns, and it is having a narrow based budding. And the mold face appears to be in the form of lollipop. The culture technique is similar to that of the blastomycosis. Here there is slow growth and it takes around 6 weeks. The E cells when stained in LPCB shows the mariner's wheel appearance. And other laboratory diagnosis include skin test with paracoccidioidomycosis, antibody detection with complement fixation test, enzyme linked immunosorbent assay, that is ELISA, counter immunoelectrophoresis, and the nucleic acid detection by DNA probes and PCR. And animal pathogenicity can be performed in mice, rats, and it is used to study their virulence. Itraconazole, fluconazole with amphotericin B and ketoconazole can be used for the treatment of paracoccidioidomycosis. The next systemic mycosis is the coccidioidomycosis. The coccidioidomycosis is an infection caused by the dimorphic fungus Coccidioides immitis. The infection may be inapparent, benign, severe, or even fatal. The disease is endemic in the dry, arid regions of southwestern USA, where the fungus is present in the soil and in rodents. Infection is acute by inhalation of dust containing arthrospores of the fungus. For example, digging in soil produces aerosol of arthrospores, and the inhaled arthrospores establish a lung infection. And these arthrospores develop into sporules that produce endospores, and these endospores are released in the lungs. In the case of an immunocompetent person, they can effectively fight infection and return to health, whereas in immunocompromised people, it can develop meningitis, osteomyelitis, and skin granulomas. In majority of the case, it is asymptomatic and leads only to immunization. The pulmonary disease will resemble mild influenza like fever, and then it can extend even to pneumonia. Dissemination is uncommon, but if it occurs, it is highly fatal. For laboratory diagnosis, the specimens can be sputum, pus, and biopsy. On direct examination with microscopy, the yeast worm will be appearing as spherules with thick double-walled refractile pall filled with endospores, and in the mycelial form there is pseudohyphae which fragments into arthrospores, which is highly infectious. And the culture technique includes cultivation in SDA or brain heart infusion agar with cycloheximide and chloramphenicol. It can be incubated at 37 degrees Celsius and 25 degrees Celsius in order to observe the dimorphic property. Arthrospores are highly infectious, so never use petri dishes for culturing Mycoses. And the skin test is performed with delay type hypersensitivity to the antigen coccidiorin. And for interpretation, if the test is positive, 5 mm in duration will be observed within 48 hours. And in the endemic areas, this test is not useful. So the next systemic infection is the histoplasmosis. Histoplasmosis is an intracellular infection of the reticuloendothelial system caused by the dimorphic fungus Histoplasma capsulatum. The disease was originally described by Darling. So it is otherwise known as the Darling's disease or reticuloendothelial cytomycosis, or the Caver's disease or the Spelunker's disease. The disease is worldwide in distribution but is most common in the USA, where it is endemic in many central and eastern states. In endemic areas, the fungus is present in the soil, rotting trees, and is particularly abundant in bird fecus. Infection is acquired by inhalation. The reticuloendothelial system is involved with resultant lymphadenopathy, hepatosplenomegaly, fever, anemia, and a high rate of fatality. Majority of the case it is asymptomatic, but some infected persons develop pulmonary disease which resembles tuberculosis. Disseminated histoplasmosis develops only in a small minority of infected individuals. Also, there is granulomatous and ulcerative lesions develop on the skin and mucosa. For laboratory diagnosis, the specimens can be sputum, bone marrow aspirates, peripheral blood, skin scrapings, lymph node of biopsies, and biopsy of other organs. For microscopy, staining can be done with Giemsa stain or Wright stains, and the histoplasma capsulatum appears as small oval yeast cells packed within the cytoplasm of macrophages or monocytes. Culturing done on SDA or BHI agar with cyclohexamide and chloramphenicol, and it is incubated at 37 degrees Celsius and 25 degrees Celsius, and the yeast forms appears at 37 degrees Celsius and mycelial forms appears at the 25 degrees Celsius. In the mycelial forms, they can be seen as large, thick-walled spherical spores with tubercles or finger-like projections. And after 2 weeks of infection, antibodies can be detected with the following tests such as latex agglutination test, precipitation test, complement fixation test, and there is rise in the antibody titer with progressive disease. For the skin test, delay type hypersensitivity due to the antigen histoplasmin is performed. For the treatment, amphotericin B is used. There is another type of histoplasma that is called as African histoplasmosis, that is caused by Histoplasma dubosi, and it is mainly occurring in Africa. It primarily involves skin and subcutaneous tissues, and lungs are usually not involved. The morphologically similar to the mycelial phase of Histoplasma capsulatum, and they have a larger and elongated yeast forms compared to the Histoplasma capsulatum. So there came to the end of systemic mycosis. Now let's see the opportunistic fungal infections or opportunistic mycosis. Opportunistic mycosis is a fungal or fungus-like disease occurring in a human with a compromised immune system. Opportunistic organisms are normal resident flora that become pathogenic only when the host's immune defenses are altered. For example, in the case of immunosuppressive therapy, in a chronic disease such as diabetes mellitus, steroid or antibacterial therapy that upsets the balance of bacterial flora in the body. The opportunistic fungal infections with highest frequency are Candidiasis, Aspergillosis, Cryptococcosis. Candidiasis or monoliasis. They are normal flora and they exist in mouth, gastrointestinal tract, vagina, skin in 20% of the normal individuals. They are called as yeast-like fungus. They are currently important cause of opportunistic fungal infections. Morphology and culturing of Candida. They are ovoid shaped or spherical budding cells and produces pseudomycelium. They can be cultured in SDA or sebose glucose agar. They grow predominantly in the yeast phase. A mixture of yeast cells and pseudomycelium and true mycelium are seen in vivo and nutritionally poor medium. And in this image you can see the macroscopic, that is the cultural image of the Candida species, and also the microscopic image. From opportunistic candidiosis, systemic candidiosis occur in patients who carry more yeast in mouth and gastrointestinal tract, and there are also some other predisposed factors with individuals on antibiotic and steroid therapy, the individuals who are immunosuppressed, recipients with organ transplantation, infant, old age, pregnancy, indisposed with trauma occluding lesions, patients with diabetes mellitus, and person who is having zinc and iron deficiencies are also more prone to systemic candidiosis. Besides the factors mentioned earlier, the use of IV catheters, use of cytotoxic drugs and corticosteroids, and urinary catheters also results in systemic candidiosis. The most important species of Candida and human infections include Candida albicans, Candida tropicalis, Candida glabrata, Candida krusei. Skin scrappings, mucosal scrapping, vaginal secretions, culturing of blood and other body fluids can be performed for the lab diagnosis of candidiosis. On gram staining, gram-positive yeast cells can be observed. Beside gram staining, KOH preparation and methylamine silver staining can also be performed, and the culturing can be performed in SDA, blood culture media, also sheep blood, trypticose, soy, agar. Easy identification of Candida albicans can be done with a germ tube test. It can be used to distinguish it from the other Candida species. It is based on its ability to form germ tubes within 2 hours when incubated in human serum at 37 degrees Celsius. And other methods include the molecular methods like PCR for the detection of Candida infection. Next opportunistic infection is the cryptococcosis. Cryptococcosis is an infection that is caused by the yeast Cryptococcus neoformans. It's a capsulated yeast or a true yeast, and the disease caused by it is a sporadic disease in the past. It's most common infection in AIDS patients. It's a true yeast and it is round and 4 to 10 microns. It consists of a capsule that is made up of mucopolysaccharide. On negative staining with intent and nigrosin, you can observe the capsules. KOH preparations are made from sputum and other tissues. Periodic acid skin stain and mucicaramine stain helps in the confirmation of cryptococcosis. You can see the capsule when Indian ink staining was performed. It is a soil saprophyte and is particularly abundant in the fecus of pigeons and other birds. Infection is usually acquired by inhalation but may sometimes be through the skin or mucosa. Most infections are asymptomatic, and inhalation into the lungs lead to the lodging of the organisms into the alveoli, and dissemination of the infection lead to visceral, cutaneous and meningeal diseases, that is affecting even the central nervous system. And the visceral forms stimulate tuberculosis and cancer clinically. Bones and joints may also be involved. Cryptococcal meningitis is the most serious type of infection and can resemble tuberculosis or other chronic types of meningitis. For laboratory diagnosis, the sample can be cerebrospinal fluid as it will result in meningitis often. And for direct microscopy can be done with gram staining. And cultures can be cultivated on SDA. Serological test for detection of capsular antigen involves lab test for detection of antigen, blood cultures, ELISA. For the treatment of immunocompetent person, fluconazole and itraconazole can be used, and for immunodeficient patients, amphotericin B and flucytosine can be used. The next group of opportunistic systemic mycosis is aspergillosis. The few important human pathogens in Aspergillus include Aspergillus fumigatus, Aspergillus niger, flavus, teres, nudulans. Allergic aspergillosis occurs in atopic individuals with elevated levels of IgE. 10 to 20% of asthmatics react to Aspergillus fumigatus. Allergic alveolitis follows particularly heavy and repeated exposure to larger number of spores. Maltster's lung is caused due to allergic alveolitis to handle barley on which Aspergillus flavus has correlated during malting process. Aspergilloma is a condition in which a fungal ball or fungus colonize pre-existing cavities in the lung and form compact ball of mycelium which is later surrounded by dense fibrous wall. The clinical features include cough with expectoration, and there can also be hemoptysis. It means the spitting of blood that originated in the lungs or bronchial tubes. It is cultured as mycelial fungus, and Aspergilli have septate hyphae. Asexual conidia are arranged in chains carried on elongated cells called sterigmata, borne on the expanded ends of conidiophores. The next group of opportunistic mycosis is the zygomycosis, and it is saprophytic mold fungi, and the major causative agents in it include Rhizopus, Mucor, Absidia. Mucor on microscopy can be seen as a non-septate hyphae having branched sporangiophores with sporangium at terminal ends, and there is no rhizoids present in the case of Mucor. And in Rhizopus, it shows non-septate hyphae, the sporangiospores in group, and they are above the rhizoids. Rhinocerebral zygomycosis is associated with diabetes mellitus, leukemia or lipomas. It causes extensive cellulitis and tissue destruction. The incidence of the disease has increased considerably as a result of the widespread use of antibiotics, steroids and antimetabolites. Zygomycosis is also termed as mucormycosis as it is a disease caused by the Phycomycetes species, that is Rhizopus, Mucor and Absidia. The cellulitis causes extensive tissue destruction and it spread from nasal mucosa to terminate bone, paranasal sinuses, orbit and brain, and it will be rapidly fatal if it is left untreated. Other opportunistic mycosis include otomycosis. It is a fungal infection of the external ear. It is a very common disease and is usually caused by the species of Aspergillus niger, Aspergillus fumigatus. The symptoms are itching, pain and deafness. Diagnosis can be made by the demonstration of fungi in scrapings and by culture. And the next one is the ocular mycosis. Mycotic keratitis usually follows corneal trauma. In this, the fungal spores colonize the injured tissue and initiate an inflammatory reaction. Also, the widespread use of corticosteroids in ophthalmology has resulted in an increased incidence of keratomycosis. Many saprophytic fungi can cause ocular infections, and it include Aspergillus species, Fusarium, Candida albicans. Diagnosis can be made by the examination of deep scrapings. Local application of amphotericin B nystatin may be useful for the treatment of ocular mycosis. The next one is a penicillosis. Penicillium species have been responsible for the cause of penicillosis. Penicillium marnefi has been reported to be an important opportunistic pathogen in the HIV infected patients.